Recording's on. All right. Welcome, everybody. This is... Can't do that. I'm going to cut all this first part out. Maybe not. I don't know. All right. Welcome to the Unboxing Performance Podcast, a sports physical therapy podcast meets training. Our goal here is to better understand how to define performance at all levels of play and practice. We strive to provide the most current evidence-based practice that will help educate not only ourselves, but athletes, undergrads interested in physical therapy, current SPTs, and even young professionals surrounding the physical therapy world. We want to just provide an easy to digest form of media. We're trying to create content that's going to educate, but also promote the field of physical therapy, specifically as it relates to sports. My name is Vito. My background is I grew up playing sports. I played football. I played baseball. At some points, I played basketball and wrestling. Played every sport you could think of, except for hockey. Went to college, played 4 years at Division II at the University of Indianapolis, and got into training, spent a lot of time in the training room, learning, dealing with injuries, learning how others are dealing with more advanced injuries. I was lucky to only have a couple bad ones, but fell in love with the idea of rehab. And a couple years down the road, got into PT school, and here I am, and pass it over to you.
All right. Well, my name is Vince. I'm also one of Vito's classmates at Regis. Growing up, played pretty much all sports, mainly focused on football and wrestling. Those were my main two. I also played rugby in high school and got a chance to work as a trainer for a couple years post high school. Worked with mostly college and high school athletes, working on strength conditioning programs and learning how to best modify training for primarily jiu-jitsu and football athletes because of the niche population I was working with, and ended up in physical therapy through that and through the influence of some of my coworkers that were further along in their education, and found motivation in finding how to better treat athletes and work around impairments and injury, and just really trying to figure out how safe and how to optimize an athlete's potential as they progress off season and on season. And yeah, that is all I have to say about that.
I think that's probably a pretty common story that we both share for a lot of people getting into sports PT. There's a love of training, there's a love of sport, and then there's also this need to learn more. And I think that's what one of our real focuses is here. So, I mean, we're going to be taking a competency exam in a couple months. And so we're using this platform to educate, talk about topics that are like important to us in physical therapy and in training. We want to try and bridge that gap, but also solidify everything that we're trying to learn so we can be the best physical therapists we can be when it's time to enter our third and fourth clinical rotations before we get out in the world. So the topic of today is going to be concussions. We'll have some ortho MSK stuff coming up. We'll have some training specific stuff. We'll maybe get to BFR in an episode or two, talking about some cool training aspects. But today, concussions. So it's an interesting topic for sure. We both played football. I played lacrosse, wrestling, combat sports. It's going to happen. It's a contact sport. And one of the ways we define it in literature, sports-related concussion, the mechanism of injury is something you'll discuss a lot in physical therapy school. The mechanism of injury for an SRC is caused either by a direct blow to the head, face, neck, or anywhere else on the body that causes an impulse to be transmitted to the head. That is directly quoted from the Consensus Statement of Concussion Sports from the CISG held in Berlin in October 2016. So that's the most clear, well-rounded definition of the mechanism of what a sports-related concussion is. It's typically going to have short-lived impairments, quick onset, most resolve within 10 to 14 days. If it doesn't, then it kind of shifts into the more chronic concussion where we have persistent concussion syndromes. And that's where a lot of physical therapy, especially in outpatient and younger populations, are going to have their role to play. If you're working in a professional league or you're working, in a school where it occurs, you might see more of the acute phase, but we're going to be dealing with a lot more chronic symptoms. And that's what we're going to talk about a lot later. So there's a lot of different clinical signs and symptoms. There's a couple different buckets, but let's go ahead and talk a little bit about the epidemiology, the prevalence, and some of the statistics that we see in sports with concussions.
All right. So one very niche-ish but growing population is the mixed martial arts community. A lot of contact. Obviously, the MMA promotes head striking and ultimately trying to create a lack of consciousness in your opponent. So that's going to involve a lot of trauma, actually, if you're not surprised. Um, and and because MMA is such a new sport, actually starting up in the last 30 years, which may sound pretty pretty old, but it's pretty recent in the grand scheme of research. So in 2021, the UFC actually just formatted their own concussion protocol, which they hadn't had one up until then. And UFC has been around for the past couple decades now. And what they found was the involvement of physical therapy as it proceeds back to return to play. So that was published in 2021 by the clinical sports medicine community and the Journal of Exercise Rehab. So essentially, post concussion, they usually wait. Well, their stages are 5, and they'll usually wait about 24 to 48 hours to essentially watch the patient's vitals and make sure that they're monitored safely. Usually given a acetaminophen to help reduce the inflammation and basically control any symptoms that they may be experiencing, whether that be confusion or just some mild amnesia. And then they will be assessed by a physician and PT and moved forward. And then this is going to transition into more of our interventions list of things that we have written down. Yeah, if you want to start that up, Vito.
Well, before we get there, let's start with let's go back because I want to get a couple more out there, and I think this is a really interesting thing. So another article we were looking at from Purepoint and Collins is the epidemiology of sports-related concussions. This came out from the Clinton Sports Medicine Group in 2020. So they reported that for every 10,000 athletic exposures in football in the high school high school age groups, it's 25.73 exposure. So that's practice or competition. There's a concussion sustained. And that goes up in college to about 30. And when you look at the practice compared to competition, it's 5 times less in high school and 6 to 7 times less in college, which is kind of a fascinating thing there. You're looking at competition versus practice, and the less control it gets, the higher the risk of concussions. And that goes for all sports. If you're looking at men's football, baseball, basketball, hockey, lacrosse, soccer, wrestling, women's basketball, field hockey, lacrosse, soccer, softball, volleyball, the risk of a concussion is significantly higher in competition, which, makes you wonder about, controlling yourself in space, especially when there's opposing teammates around you. It's just an interesting thing. You'll see football leads the way in total number of concussions in high school, followed by hockey, followed by lacrosse. In college, it's football, followed by hockey, followed by wrestling, actually, which it goes from having about 5 per competitions to about 28 per competition in college. So it talks about the ferociousness of the sport as it grows. Let's see. Yeah, let's go ahead and talk about examination and then get into some interventions and how that goes. So a nice free option or resource for anyone who's interested in PT or currently in PT. If you're currently in PT, you've probably already seen it. It's called a clinical practice guideline, a CPG. We have one of those for physical therapy concussions. And if you go to page 38 on it, it walks you through basically how to do your job. It's so easy. It's so simple. And it takes a lot of questions out of there for you. Concussion event occurs. The first thing you're going to do, you're going to screen for emergency medical conditions, observe, examine, interview what happened, take a couple outcome measures. The gold standard for concussions is the SCAT-5. It is really helpful on field, on the sideline, whenever it occurs. its value kind of decreases as days pass, similar to Glasgow. So concussions are kept under the TBI umbrella. It's considered a mild TBI. There's discussion about whether it should be considered under there, because typically with the TBI, you have trauma with structural damage. And one of the articles we have in here from Cassandra Castle, MD, and Elisa Torres, MD, from 2019, and their definition and classification and epidemiology of concussions is that there's no neurological structure or physiologic changes occurring on imaging in MRIs or CTs. It is diagnosed from a clinical change in neurologic function, which kind of leads us into our different kind of buckets. So when a concussion occurs, the symptoms and the signs, they vary in how they present. One that we see a lot, especially for sports, is the physiologic. That means exertion sets the symptoms up, and the symptoms can be dizziness, it could be fogginess, it could be headaches, it could be nausea, vomiting, it could be unable to focus, and loss of balance is another part. So we have as you exert, symptoms come on. Then we have impairments in our vestibular system. Vestibulo-ocular is going to be your eye movements oriented to space. So any sort of loud or moving environments can set those symptoms up. Vestibulospinal is going to be balance impairments. So balancing on one foot, stepping on grass, stepping on a foam surface, you're going to have a lot more errors. You're going to have a lot more deviations if your vestibulospinal system has been damaged or impaired. And then there's also the cervicogenic headaches. So when you have cervical problems that bring on those symptoms, and then am I forgetting one? That's three: physiologic, vestibulo-ocular, vestibulospinal, and then kind of on the side is cervicogenic. Is that all of them?
Yeah, I believe you kind of covered most of that.
Yeah.
How are we going to measure severity, though?
So one of the nicest tools that we have that kind of directs us into where we want to go is the VOMS. So that's going to measure saccades, which is the eye movement side to side, same for or horizontal. We have the look to the left, the look, you move your eyes. What's that one? Extinction tests.
There you go.
There we go. Pulling it back out. So there's going to be a whole list of examination measures that's going to be focused on eye movement and head movement in space. And then we rate those on the changes of symptoms 0 to 10. Super easy. The VAS scale, you can put it for almost any kind of symptom, whether it's pain, dizziness, fogginess, all the ones that we just talked about. Other great one that's used for concussions a lot. And actually, we with Regis partner with a school named Arupe Jesuit High School, serves disadvantaged groups or underserved populations, and we do concussion screenings through their sports program. And we use the best test, balanced air scoring system. We have three different balanced setups on two different surfaces. So the first one you'll do is you're just going to stand feet together on firm ground, go to a single leg stance on your non-dominant leg, and then tandem. And we just count how many times you make deviations. And we have, it could be lean in too far one way, foot pops up, touch the other leg, all that kind of stuff. Document how many you get. Then we do all those same tests on a foam surface. So we use those errors to kind of see where your baseline is. Then after you have a concussion or experience a concussive event, we go back through and we test all of those again. And if it's setting off your symptoms, no score, great. We know that that's impaired. If it's way higher in the number of errors, great. We now have a outcome measure that we can compare against as we get back to baseline to track your improvement and your changes. So those are two big outcome measures that we use from examination. We call them asterisk signs to check your status over time. And then we also have so those are your balanced ones, your vestibulo-ocular, and then lastly, the graded Buffalo test. It's a treadmill test. You can do it on a bike. There's debate if there's too much head movement while you're on the treadmill and it's setting off symptoms, that could make you want to go to the bike. It's a similar test. It's the same parameters, except you're changing resistance instead of incline. But it does keep the head in a more stable position, so it may not be as aggressive. Do you see that thumb?
I do see the thumb.
I don't know what that means.
I I'm trying to click on it,
It's gone
but
now.
it's gone.
Interesting. Okay. So graded Buffalo test. We'll talk about the treadmill first. Basically, we're doing the same thing that we did with the bombs. We're trying to track your symptoms change. We'll set it up on a speed that works for you. Typically, it's set at 3.2 or
I believe it's adjusted via height. So
yeah.
I believe the cutoff is around 5'5" to 5'6". I would have to look back at the actual protocol for it. And
Yeah.
it's the difference between, I think, it's like 0.6 miles per hour, where people under 5'6" will walk just a tad bit slower than people higher. And that just has to do with foot length and cadence and just stride length, because obviously if you're shorter, you're not going to have as big a step. So we have to adjust accordingly for that. Right. So makes sense.
Yeah. So adjust the speed to make sure it fits, and then we up the incline, and wherever the symptoms get above 2 jumps, we talked about the VAS scale, it's that. So we set you, say your baseline's a 2, you get to a 4, boom, cut it, or we get to a 5, we go up by 3. Once you've gone up 3 points in your symptoms, cut it off. Great. We know where to train you from. So those are the ones. So we have graded Buffalo concussion treadmill test for physiologic exertion. We have our VOMS to test our vestibulo-ocular system. We have our BEST to test our vestibulospinal system. And then we can also always, post-concussion event, check for cervical impairments. So that's going to be doing your down glides, your up glides, checking rotation, active range of motion, passive range of motion, muscle length testing, tenderness to palpation, spasming, guarding, motor control, all those things that could be contributing to poor head posture or anything that may be eliciting those symptoms, especially that ram's horn headache. All of those can be something that we manage while working with concussions, especially if it's increasing those symptoms. Mm-hmm. So that's kind of where our examination and our interventions start to blend. Yeah. So let's go ahead, and I think now's a good time. I can pull up the return to sport because I think it blends well with interventions. What are you thinking there?
Yeah, I think that's a good thing.
Or is there something else we want to go over first?
I think we could probably cover like habituation within the intervention stuff.
Cool. All right. So yeah, let's pull this up, and yeah, we'll kind of talk about all of it because I think this really is helpful. So article here by Mario Bazzini. He's a PT PhD who works with the NHL and elite hockey players. And so the CISG, the same group that we used their definition of concussions for before, released a graduated return to sports strategy. What that means is we have a nice systematic way to bring people back into sport, from physical therapy and athletic training and whoever else is on the team with these players. The higher level you go, the more people you have involved. So if you're working in an outpatient clinic, this is a great place that you can use to guide your treatment. Stage 1, it's symptom limited activity. So we're basically just trying to not provoke symptoms. We want it to go down, go down, go down. Once we have that under control, we're going to shift to light aerobic exercises, walking, stationary cycling, slow and medium pace, no resistance training. The reason they don't encourage resistance training, especially at this point, is the concussed brain. When you're performing resistance training, especially with heavier weights, your blood pressure goes up. Brain doesn't respond super well to that blood pressure increase, often increases those symptoms at a point where we're trying not to. So bands, great. Stretching, great. Banded resistance, light banded resistance is okay. Avoiding the dumbbells, avoiding the barbells, all that kind of stuff. And then light aerobic again is that that stage.
I think what's important behind that also is the patient report during it all, because in order to progress safely, you do want to somewhat stimulate their symptoms, but not to the point where it shuts them down completely. So I think that's where the education piece on our side comes in, and knowing when and how far to push someone to their tolerance. Obviously, you talked about the visual analog scale, the VAS, and we don't want to move them by any 2 or more points at one time, but over time we want to be able to increase tolerance. So they may start the day at a 6 with head pain, having ram's horn, and if we could somehow alleviate, we may proceed that way. Or if we're able to maintain that 6 and exert them a little bit more, we'll keep it there. And just being able to walk that tightrope, essentially, of poking the bear in one way or not, for lack of a better term, and knowing to keep it asleep as long as possible.
Yeah, I think that's a great point to target. So let's go to vestibulospinal real quick. And vestibulocular, the vestibular system, the primary way that at least that we've learned so far to reintegrate those systems that may be disrupted or impaired, habituation, sensitization, substitution. Primarily habituation is where it's that graded exposure, right? That you were just talking about. We want to encourage the system to work, and the symptoms may rise, but if we can hold the symptoms at that same point. So let's talk about a specific thing then. Single leg. Yeah, let's go with no, we'll go with like horizontal saccades. That's a pretty easy one. Say they walk in at a 2, right? They're looking side to side. Those are the ones setting it off.
Right.
Is it this way or this way? I don't remember. I think it's
so
eyes.
Horizontal will be side to side.
I know, but is the head movement or the eye movement?
So the saccade has to do with head movement, because
so focusing.
Smooth pursuit are going to be the eyes.
Yeah. Okay.
Saccade's going to be
doing horizontal saccades. You're focused on a single point. Say, all right, I'll give you a brief example and tell me what you would do. So we got the stick up there. It's like 24 inches away from the face, about 2 feet. It's got a letter on it. They can clearly see it. And we have them doing this. Right now, the lights are on. We're sitting in the middle of the gym floor, and their symptoms are frying up. What do you want to do to regress that? Like, what are you going to do?
So there's a few.
They're at a 2, and it's shooting up to a 5.
Right. So we'd pause for a second, let them trying to calm their symptoms down. There's a couple ways you can regress it, though. You can either decrease the range of motion that they're having their head turns at, either reduce that. If the background behind what they're looking at is kind of noisy meaning like there's a lot of action going on. If you're in the middle of a gym, there's other people walking around and stuff. So you're going to want to reduce that background noise, essentially. So maybe take them to the corner of the gym, to a blank wall, somewhere that will limit all the feedback their eyes are receiving at that time. Another one you can probably do is, I would say, take them out of the environment completely, bring them to a private room, maybe an examination room if it's available, and have them practice in there and just see which one modulates symptoms the best. I would probably start with just bringing them to a blank wall so they have less visual stimulation during their training. And yeah, those are 3 of the ways I'd probably regress them a little bit. They're not doing too well.
Yeah, I think that's great. And then again, it just goes back to rating their symptoms. Say they were going from a 2 to a 5. Oh, that's too much. We bring them back. Now they're going from a 2 to a 3. It's only going up by 1. Great. Let's hold there. Once they can stay at a 2, then we can kind of progress it. All right, we can add a little more background noise. We can move it away. We can change the object that they're looking at. We can change the setting we're in. We can change the position. Maybe we take them from sitting to standing. Now they're also engaging their balance system. If you have them on narrow base while also doing it, that's going to be a lot more things coming in. And you can tackle 2 birds with 1 stone. I'm pulling up because I think Rachel Carter, PT, gave us some pretty good things when we were doing our graded buffalo exposure test about physiologic graded exertion. And I'm going to pull that up real quick just because I think it's super valuable. We want to dose appropriately when we're looking at concussions. especially when it comes to physiologic. So one of the things that we're going to get when we do the graded buffalo test is we're going to get the heart rate or the RPE that is causing symptoms, and we're going to take 90% of it. So we're going below the point that increases their symptoms above that 3 point increase in the VAS scales, and that gives us a great heart rate to work at. And then from there, let's see if I can find it. And if I can't find it, then we'll just talk about it. But all right. So back to graded uh, graded exertion in return. 90% of that 3 point jump in symptoms, that's where we're working at. So we're instigating a little bit of rise, maybe a little bit of dizziness, a little bit onset, and we're going to stay there for however long we clinically decide. So when we say clinically, it means that there's no specific parameters. It means that we get to make the judgment. We've had the training, we've had the exposure, especially for us who've worked in sports. There's going to be different populations that can exercise for different amounts of time, for different amounts of intensities. We have our goal intensity, we have our goal speed, but we got to figure out how long that they can handle that. So one of the things we're going to use is that VAS scale that we're talking about. Probably have a piece of paper that says 1 through 10, smiley faces, and we're having a point to it. One of the things that I think is really helpful is when, even though we're doing like this lower small test, as opposed to what they're typically training. So say you're working with a football athlete, a receiver. He's a big sprint. He's got, quick fibers. He's super fast. He can run for a while. Same thing with the corner or safety. This kind of training is going to be, outside of their symptoms, really low level to them. So walking at a speed of 3.2 miles per hour at 6% normally is going to feel like nothing to them. This is going to be a little bit more challenging, but we still need to warm them up to get them there. So one of the American Heart Association suggests about 5 to 10 minutes of performing a low level version of the thing that you're going to do. So if you're going to have them at incline, say 9, 10%, 6%, start them at 0. Make sure you're warming them up there, engaging them, talking through, make sure symptoms aren't changed. Just talk about their day. Don't overstimulate them, but make sure if they've had some event that really stressed them out earlier in the day that might have changed how they're going to react to the test. You can kind of feel them out there. Then to progress that, think about what you're getting them back to, right? So we're in stage 2. We're doing light aerobic exercise. They might have a practice for 2 hours where they're doing, endurance or running for 60 to 80 of those 120 minutes. They're moving around a lot. So that's our end goal. You can break up how we get there. So say today, day 1, we're at the 90% mark. Get them on there for 20, 30 minutes, see how they respond. Make sure you note how they respond, and then you can see how you progress from there, 1, 2 weeks down the road, 2, 3 sessions down the road, up that, and know that you're trying to get them to be able to perform some sort of aerobic activity for somewhere between 60 and 80 minutes. So just know your patient, know where you're getting back to. And I think that's really important for the return to sport aspect. We didn't really finish going through the stages, but I kind of want to just bring that up, that we as clinicians need to be able to make decisions like that, where if there's no literature, go with what you know about your patient, what they're trying to get back to, and use the tools that you have around you, like the CPG, like the CISG guidelines, to guide that. So that's kind of, all of that kind of ties into that stage number 2, light aerobic exercise. You're already probably doing your vestibulo-ocular and spinal retraining there. I hope you're doing balance. That always goes, at least in the experiences that I've had, a lot of times patients are going to fit into multiple categories. Once you progress past that light aerobic exercise, then we can start getting back into the sport specific stuff, the running drills. In hockey, it might be skating drills. It might be in the training room. It might be on the ice. Once we can get them there and their symptoms are managed, then we can get back into training, no contact if it's a contact sport, no risk of head impacts. If it's, soccer, no head in the ball, probably not smart. Basketball, maybe don't stand under the rim, catching rebounds, stay shooting on the outside. You can start, once you get to that stage 4 where there's non-contact training drills involved, that's when you can start mixing those weights back in, up that resistance training. Then we get back to that full contact practice. You're participating in all practice. Final stage, which I think we kind of alluded to a little bit earlier, competition is where most concussions occur as opposed to practice. We want to make sure that you have got your bearings, you have control of your body, you're watching everything around you. When you're in practice, you know what's going on before we get you back to that competition level play, because that risk goes up. Those are the 6 stages. One of the things that Bazzini talks about too is that there should be different and more individualized protocols per sport. We're seeing them come out a little bit more. This one that he wrote for hockey, or has produced for hockey, is fantastic on showing sport specific optimized training through all of those stages. There's a international soccer one that's out there that's pretty good. Football has their own, which I think could be expanded on. I think it's kind of limited. And then we talked about UFC's protocol that they have.
Yeah. So they broke theirs down into 5 steps, very similar to essentially what you were explaining. Stage 1 is just going to be that initial recovery. So the first 1 to 2 weeks, depending on the patient's presentation. And then right away, we go into non-contact. So it's going to be that low intensity aerobic exercise you're talking about. And depending on where they fall, we're going to see a lot of like balance training. We're going to see a lot of exertional tolerance and habituation in that sense. And we will progress them into a stage 3 for the UFC. And that's going to be more of just that essentially aerobic, sport specific training. So they're going to be a lot of shadow boxing. There's going to be a lot of just shadow rolling, which is going to be just you by yourself on the mat, essentially like motor imagery, like walking yourself through what you're grappling or what your style is going to look like in that case. And then once they deem you ready, you'll roll into a stage 4, which is moderate contact. So this is going to be just like gradual pummeling, which is not as violent as it sounds. It's just you and your partner just kind of tossing your hands around and just getting a feel for what it's like to have someone else's hand on you, whether that's on the mat or with the gloves on. So we're going to do some bags. So you're going to have a little bit of impact behind your fist, which may reverb up, but depending on your symptoms, you should be okay at this point to continue. And then we get into stage 5, which is the full return. So you're going to be back in doing some live sets and actually trying to inflict some harm on your partner within reason, and just really getting back into the grit of it and training at full competency, ideally.
And I think the thing that's left off of here that we've discussed quite a bit, especially when we're going through our lower extremity series, is that stage 6, return to competition play, does not mean that this player is back to where they were performing prior to the concussion event. Mm-hmm. Return to performance is that step beyond, and it's talked about in a lot of different articles that's out there, especially if you want to learn about optimizing performance. Look up anything on Google Scholar, PubMed, return to performance physical therapy. You're going to hear some stuff about it. It basically means that when they're done, especially in the outpatient, insurance-based system, you're going to see people, you're going to discharge people because their insurance is running out. Hopefully you've done everything you're supposed to do. And, we're not going to get into the ethics of that, but when they're leaving you, it's because they're cleared to play. There's a big education piece and opportunity in, professional sports and cash-based system, that if your player is not performing at the level that they were playing at beforehand, this is where you can kind of put that trainer cap on. We are all, when you become a physical therapist, we all have a training background at this point. You're going to go through exercise foundations or applications where you learn how to do resistance training. You're going to learn how to do flexibility training. You're going to learn how to do aerobic exercise training. That is all in your wheelhouse, and especially important for a sports population. So when you're looking at this player and their powers decrease, but they're able to play, when they're at that final stages, implement some power training. If their strength is down, implement some resistance training. If their endurance is not what it was, give them a program to get back into cardio. If they have persistent MSK issues, pain in the shoulder, pain in the neck, from it. Give them their HEP that's going to help support and bring back the motor control, bring back the strength, bring back the endurance, support them as they get back so that they have a roadmap if you're not going to see them again to get back into where they were, even though they're not with you anymore. And I think that's just something that we as PTs have an opportunity there to shift our role from physical therapy to that trainer, role.
Yeah. I think you bring up a good point, and basically what I feel like you're saying is make sure at your discharge that you write them a home program that they could progressively follow well after you're done seeing them. So
yeah,
I feel like that's one way to keep yourself somewhat involved in their progression after. And that's kind of how you leave that lasting impact almost on what they're going to see. And then I also think it's important, and what I've seen in clinic is to let your patient know that you can be a resource for them in the future. During my time in the clinic, I worked in an outpatient MSK. All of the PTs there had their business phone and contact cards for any patients that were not going to be in for a while or were going to be discharged, to contact them if they had any questions about things that might be going on, mostly related to what they had initially came in for. And at the PT's leisure could give advice where they see fit, where they see necessary. And I think that goes into building that psychosocial relationship, the practitioner and patient relationship between each other, and making sure that that's strong, because you want to keep that line of connection for them, because ultimately their care is going to be prioritized in our practice. And I think that would really reinforce the idea that PT is a marathon kind of thing and not a sprint. It's getting better over time, essentially. And we want to educate them on that. So yeah, I think you made a good point with that.
The therapeutic alliance.
Oh,
we
yeah.
say that in jest. We say that in jest, but we don't, because it's real. Therapeutic alliance is, we hear it 3 to 4 times a day. So we're not making fun of the term. It's a great buzzword, but it really does matter, especially when you're involved in a patient's, like, if you really do care, you're going to build that regardless anyway, if you care about your patient's return. And that's definitely what we're getting at. Now, that fits kind of in that discharge setting where it's insurance. There's also an opportunity there. If you work in a sports clinic, cash-based, or you're working in the professional sports setting where you have either strength trainers with you or you have your CSCS, that's an opportunity. It's like, hey, you've been paying out of pocket for PT. Let's decrease that cost. Let's have you come in for some training sessions or some group fitness sessions where you get to continue in that trainer role. Because a lot of cash-based systems, you have your racks, you have your tracks, you have your sleds, you have your barbells everywhere. You can write that program at discharge and then have them come into your other hours, your trainer hours, if that's something you have at your clinic. And that's good for your bottom line too. It's good for them. It's good for your bottom line too, especially in the off season. A lot of professional athletes, they aren't working with their team clinics. They're going back home. They're going with the guys they trust. They're getting their rehab for their injuries, and then they're training. And because we have the background that we have, we can offer them a lot on top of your classic. Here's your 3x10 squats, followed by your 3x10 RDLs, and out the door. We get a lot. We have a lot of opportunities there in those cash-based sports clinic models.
Yeah, I agree. And then even if you're limited by non-cash based, you, at this point, if you're practicing, will have some kind of network as to where your athletes are going to be going post seeing you, post discharge. And you'll learn who you kind of trust with your athletes to progress them properly. I mean, you were there for the class. When we went over plyometrics in our courses, we met one of the was she athletic training, or
she was the head strength coach and is also now
head strength coach?
she's also now, I think, the director of the HES program, potentially.
Potentially. I
Aaron
see
Choice,
her.
very smart, PhD.
Yes, that's her name.
Yeah,
Yeah. So even referring to people like her who are very competent in progressing athletes at a safe rate and having some understanding of what injuries have preceded them and just knowing who to trust. Back home in California, where I'm from, I have some friends in a clinic that work behind a local gym. So once their patients are done seeing them, they immediately plug them to the gym and what they have partnership they have with them, offering them discounts of personal training. And these are usually just kines majors that have some sort of strength background and are able to coach properly and further progress them as they advance out of the more acute stages, if you will, of their injury. So I think it's just knowing who to send them to next is also very important, or knowing who they're going to and what little advice you can give them as they move after discharge.
agreed. Build your network, find your resources. It goes to build that therapeutic alliance too. If you like, hey, this is who I trust, this is who you should go if you want to keep going. Okay, I think that's episode 1. You have any other notes you want to throw in?
Can't say I do.
Okay.
Should I say
We
thank
have an
you for
email.
watching?
You should say thank you. Close it.
Thank you for watching. If you stayed this long, proud of you.
We appreciate if anyone did watch this whole thing through. I totally get if you hopped out. We're students. This is as much for us as it is for everyone else. We have an email, unboxingperformancespt@gmail.com. I'll throw it in the comments here. If you have anything you want us to talk about, if you have any comments, please be nice. Constructive criticism is welcome, but don't hurt our feelings.
Or don't be nice and hurt our feelings. We're still gonna do this.
Yeah, that's true. We're still gonna do this for us. Yeah. Next episode, I believe we discussed on doing low ankle sprains / foot anatomy. Is that right? Or do we want to do BFR next?
I say we start with ankle. There's gonna be, after this episode, we're gonna have a mild pattern of moving up the body. This is just our own way of studying for our comprehensive and boards as we get closer to that, which is kind of freaky. So we may throw in BFR later on. That is actually what my research topic is about in my narrative review. So once we have a better idea of when that'll be, we'll let you guys know.
Cool. We got an Instagram, Unboxing Performance, and hopefully that'll be live here shortly once I get my graphics from my cousin. And then, yeah. All right. Till next time.